Our next speaker is Dr. Dipten Sarkar. He is Chief of Breast Services and Breast Cancer Research Unit, IPGMR, Kolkata, and Hawk Visiting Professor of Mayo Clinic, Rochester, USA. He is Surgical Tutor of Royal College of Surgeons of Edinburgh, and he is immediate past President of ABSI. He'll be talking on practical approach to Birads Category 3 lesions. Over to you, Dipten, sir.
Thank you very much. Give me a time to share my screen. A warm good afternoon to everyone. And it's quite an enigma to speak on a topic of, as I said, as you have suggested, Birads 3 lesion. And the best analogy I could draw was Mona Lisa and the failed Rebecca. We all agree to the fact that most of the lesions that we get in the breast either are clear-cut fibroadenomas or clear-cut malignancies. But as in life, as in art as well, we have shades of gray in between. And today we are going to take on this issue of the practical approaches to Birads 3 lesion. This is a quite intricate topic as such, and I'm sure there will be a lot of controversies which are centered around this. Before we go in, we need to understand the basic fact that in mammogram, a mass with associated microcalcification, with architectural distortion, with asymmetry of architecture and density and skin and nipple changes are what are classically malignant lesions. And we have a large number of views. We would commonly resort to the craniocaudal or the mediolateral oblique views. But at times, as you will understand, in certain lesions where we have doubt, we may have to choose any of these views so that we can upgrade the Birads 4 lesion. Now, again, for postgraduates to understand is that if you look at these lesions, there is whatsoever no doubt. If you have looked at these lesions, there is whatsoever no doubt. But there is a large number of lesions in between, which your radiologist is also uncertain. And quite often, they will leave it to your clinical understanding. And very frequently, they would write, clinical correlations, excision biopsies are recommended, blah, 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 because they are unable to understand what it is and able to understand that you can stamp it as a malignant lesion or a benign lesion. And that's exactly what is a Birads 3 lesion. In ultrasound, again, to brush up your knowledge that when you see a lesion which is taller than its wide, and when you have a lesion with acoustic shadowing, with microcal and hypoechogenicity, you are looking at possibly a malignant lesion. Now, this is a classical example on one side that you see a lesion which is irregular with acoustic enhancement, and that's a malignant lesion, and a lesion is taller than it's wider. And this is a clear-cut lesion, once again, to tell that this is a benign lesion. But between these two, there exists another group of lesions. And therefore, this is stamped as the Birads 2, which is called the probably benign lesions. And it would amount to a possibility of 2% likelihood of the lesion being malignant. And the standard recommendation is a follow-up at 6-monthly interval, unless, of course, you feel that the patient has got a strong familial predisposition where you might need more frequent or more longer duration of follow-up. But having said this, the statement that is made in this international consensus symposium is again quite confusing. The reason it is confusing is, and as I said, this is the dictum that came out from the consensus statement. They are probably benign in mammogram. They have got less than 2% chance of malignancy, the need for a follow-up for 6-monthly interval, and if there is a strong family history, it may be more frequent or more longer. But as I said, the problem lies in one simple thing. This is a consensus statement made on the basis of countries who has a dedicated screening program. And therefore, for them, this is quite intriguing because this is a normal lady walking in the streets whom you call upon for a screening program, and you detected a small microcalcification, and now you are confused. So, whatever the international consensus that holds true for a country with a screening program doesn't apply for us, and I'm going to tell you why and how it should be dealt. Now look at this. In mammography, what is the criteria? Again, most of the postgraduates look at this lesion very carefully. You have a lesion which is clearly here, and this is in the breast, and you have the breast most of the times quite nodular. And most of the part of the lesion that you see, around 75% of them, are very clear. There is no confusion whatsoever, that is benign. But if you are able to subtract this away, you would find a part of the lesion, around 25% of them, which appears to be quite rugged, and that would give you the possibility or spike the possibility whether the lesion is a malignant lesion or not, and this would categorize as a Birads 3 lesion. Again, the second confusion comes is of uncertain microcalcification. As Dr. Orunima has rightly pointed, again, my breast nurse would be able to tell that these are all distinct benign lesions, benign calcifications, and there is no confusion. When we go to this type of lesions, now again, for postgraduates, I would make this statement very clearly. During the exams, you are asked what is a typical microcalcification of malignancy. Mark my word, it is said it is a pleomorphic calcification. That means every single calcification is different from the other. It has to be more than 5 dots within a 1 square centimeter area. So pleomorphism, number, and within 1 square centimeter is something which is classically a clustered microcalcification of malignancy. But in between, you can have lesions like this, where there are calcifications, and it can give you a possibility that this could be a DCIS, not to speak of these type of calcifications, which are examples of very aggressive cancers, which are not quite often missed even by the untrained eyes of some radiologists. Now look at this patient. Now this was the patient who happened to come to me around a couple of weeks back, and you look at this patient, there appears to be a lesion. Well, this is in the early 40s. The breast was till now quite nodular, and you are unable to understand, and certain areas are obscure. What we did, we magnified it. And once you magnified it, you find that there are small dots, and these are classical examples of amorphous microcalcification. We did a guided core biopsy, and the report came out this as a malignant lesion, and with examples of gross extratumoral DCIS. We had to call back the patient because this patient also had a microcalcification in this area and go for a mastectomy. So you understand these are unexplained microcalcifications which do not fit to the ones that is classically described as classical microcalcification. Now, coming to ultrasound, theoretically, an oval lesion, a well circumscribed lesion, lesions which are parallel to the skin, lesions which are more hypoechoic compared to the breast fat, lesions which have minimal or no acoustic enhancements, complicated cysts, and lesions which are hyperechoic with a central zone of hypoechogenicity and distortion due to surgical scar are defined as Birads 3 in ultrasound. You need not remember all of them. Just look at the examples that you can have. Now, this is a classical fibroadenoma that we have already described. This is again a giant fibroadenoma, or it may be a phylloid tumor. Now, I give you a lesion like this. Look at this. This is a benign lesion, but you see some clefts within the lesion. Now, once you start looking at these clefts within the lesion, you have a doubt that whether it's a clear-cut fibroadenoma or not. And again, for postgraduate trainees to remember that if you have clefts in between, those are classical pictures of a phylloid tumor. And this is again a classical example of a cleft. Now, if you have an enlarged picture, you can have these multiple clefts appearing within the lesion, yet the lesion is quite uniform. This is the hallmark of a phylloid tumor, but you cannot go beyond that to tell whether it's a malignant phylloids or a benign phylloids. You need a core biopsy to confirm. The reason I have put it here is when you see a small lesion like this in your clinical practice, you can always tell it's a young lady which is less than 30 years of age with a small little lesion, with a Birad 2 lesion. You can ask the patient for a follow-up. But such lesions with clefts would again tickle in your mind the possibility of this being a phylloid tumor and the need for intervention, whatever way you feel, to start with a core biopsy and excision later on. Now coming to the breast cyst. Now again, look at this. This is again, you can just look at the plate and tell it's a clear-cut balloon filled with water, and whether you aspirate, when you aspirate has already been discussed with Dr. Arunima. But I had a picture like this. Now look at this. This is a cyst, and on one corner of the cyst, there is a solid lesion. And therefore, this again puts you into a dilemma. So whenever a busy radiologist writes that it's a very simple cyst, I would urge all of postgraduates to look at the plate very carefully. And in certain cases, I am sure you are going to have these small solid lesions propping up from one of the corners, mandating some sort of intervention in the term of guided core biopsy. For God's sake, don't go for a blind core because you're going to aspirate only the fluid. So a guided core which goes into the solid component and takes it out is going to clinch the diagnosis, and quite often it might come out to be a papillary carcinoma of the breast. Now again, this is a classical picture. No doubt this is a starry lesion. Starry lesion is a malignant lesion. But what are the areas of confusion? Now look at this. This is a lesion which has got microlobulations here. Now once you have these microlobulations, again you are in doubt. Do I call it a star, or do I call it a clear-cut a potato? So it's these lesions which are called the category 3 lesions. And again, for a country where there is a screening program, it would put them into a lot of confusion. But for us, it becomes simple. You can go for a core biopsy. Now look at this. Again, this is a lesion which there is a hyperechogenicity here. Now, as you go, suddenly you find that there is a posterior shadowing and an enhancement. So suddenly a lesion which apparently appeared to you as a benign lesion raises the suspicion once you have a minimal or a moderate amount of acoustic enhancement posteriorly. Now look at this lesion. Again, this is a lesion in ultrasound where there is a microcalcification here. And once you have this acoustic enhancement coming up, again, that puts you in a doubt that it can be a malignant lesion, and some sort of intervention or a strict follow-up schedule has to be implemented in them. Again, for the sake of postgraduate trainees, I have put this slide, which is the axillary lymph node evaluation and how you are going to evaluate the lesions, and when you are going to understand it is clearly malignant, and when you are going to understand it is benign, and what is the in-between zone. Now look at this. This is the architecture of a lymph node. And what happens is that the malignant cells start going into the cortex. So the first thing which most of you do not know is a cortical thickening. And that is because the malignant cells are going to fill up the subcortical space. And at this stage, the hilum is not going to be effaced. And look at this, it comes later on, the hilum gets effaced. because of the fact that now the exit route is also blocked by the lymph node. So this is a classical feature of an R limitastasis. So you need to understand that you have to locate a cortical thickening, looking very carefully at the lymph node to understand that this is an early metastasis. So this is not a Birads 3 per se, but I have put it because this is one gray zone which trainees need to train their eyes to understand the early metastasis in an axillary lymph node. But as I said, this is a clear-cut lesion in the axilla, which has got a normal hilar echogenicity maintained. This is an absolutely clear hyperplastic node, and this is a globular one, which is a definite metastatic node. But I was asking you to look at the cortical thickening to understand the significance of an early metastasis. Now coming to the MRI and the Birads tree. Now these are circumscribed mass, homogeneous enhancements, and the platokinetics. I'm going to explain all three. I understand many of the trainees do not know what it is. Now look at this. This is a classical feature of malignancy. There is heterogeneity, there is architectural distortion, there is invasiveness to the surrounding parenchyma. But this is a classical benign lesion. Now look carefully, this is completely benign and it is completely smooth, just like in ultrasound or in a mammogram. This is completely smooth. It's a homogeneous enhancement that you see. But when you look at this, look carefully. This is a lesion which has got a non-mass enhancement. What do I mean by, once again, look at these non-mass enhancements. That means there is no mass, but there is an area of enhancement. And there is a type 3 curve. Again, I will tell you what is a type 3 curve. But once you see this non-mass enhancements, again, these are suspicious lesions, which there raises the possibility of DCIS and needs an intervention. Now, this is a classical example of a mass enhancement and a non-mass enhancement in MRI. Now, again, trainees look carefully at these kinetics of the curve. Now, in a classical type 1 curve, you get the contrast goes in and it goes and attains a plateau. Now, once you attain a plateau, this is a clear-cut benign lesion, unlikely to be malignant. Of course, it might come under the domain of a pre-malignant conditions with atypical ductal hyperplasia, but radiologically, they appear benign. Now you go to the next phase. The plateau is again prominent, a type 2 curve, and again it is an example that this is a benign lesion. Now this is what you need to understand, which is called a type 3 curve. Now in type 3 curve, it goes up very rapidly and it comes down very rapidly. There is no plateau. So early peak and early washout is something which raises the suspicion in MRI of the lesion being a malignant one. So when you are looking at an MRI, look at three things. Number one, you look at the mass, the architectural distortion. Number two, you look at the enhancement, which may be in the mass or in the non-mass enhancement. And number three, what is the pattern of the kinetics of the curve? And you understand what it is. So the question comes, are we missing anything? So apart from the fact that we look at the three factors that we need, we have to add in a multimodality evaluation, because at times MRI may create a situation where you have false positive. So you need to put it into other modes of radiology and compare and finally come out with a conclusion. The new kid in the block is elastography. I am sure when I was a student like you, and even a couple of years back, I did not have any idea about the new kid. Now, again, as residents or trainees, you need to understand, and this elastography really has changed the way we look at the Birads 3 lesions. By definition, it is evaluation of the stiffness of the lesion. And what do we mean by the stiffness of the lesion? Now, when we impinge our finger into a water-filled balloon, it goes inside, displaces the fluid, and once the finger is taken out, the whole thing expands. So classically, a cyst or a fibroadenoma, if an external pressure is given, it will compress and then it's going to come back to its normal position. However, it is not going to something which is going to happen in case of malignancy. Now look at this. Now this is a lesion where you have got a central lesion and there is a gross amount of desmoplastic reaction all around. So once you have this desmoplastic reaction, if you try to apply pressure, there will not be any elasticity in the lesion. And this lesion is going to be a very rigid lesion. And therefore you'll understand this is possibly a malignant lesion. There are different ways of measuring. This is called the strain or the shear wave, which is beyond your scope. But you need to understand by just looking at the elasticity of the lesion, you can further categorize as a problem-solving tool in Birads 3 and early 4A lesions. Now look at this. This is a lesion which has got high elastic score, and therefore it's a rigid lesion. And if it is a rigid lesion, it is going to be a malignant lesion. But look carefully what they have added here. They have added the kilopascal. Now, if you have a lesion which is rigid, and the objective way of measuring the rigidity is the amount of kilopascal or the strain in the lesion. If it is very high, then you understand that it's really a rigid lesion. Now look at this. This is a clustering of cysts. And look at the kilopascal they are showing. They are showing between 11 to 21 kilopascal. That means it is a compressible lesion. And once it is a compressible lesion, you know this is a malignant lesion. So as if you remember that patient in whom we had a complex cyst with a solid component on that side, if we suddenly superimpose with a color code on that and the kilopascal on that, we'd be able to tell, well, this is a lesion which has got a solid component whose kilopascal is higher than the rest of the cyst. And if the kilopascal is, say, 200, you know this is a papillary carcinoma. And the kilopascal is only 18, you know, well, this is not a papillary carcinoma, but it could be a benign papilloma arising from one end of the cyst. So ultrasound elastography can further, as in case of Birads, can be divided into score 1, score 2, score 3, score 4, and score 5. And you can add a color code. Different companies have different color code. Most of the companies would add a color red, as you see in this lesion. Most of the companies would add a color code red to understand that it is a very hard lesion, and others would add blue. But here is one company who is just putting in the reverse. So depending on the machine and the color code, just like the Doppler, you can change it. And this is again a simplified form of the Kuba score. And the Kuba score is, score 1 is a completely deformable lesion. That means it bounces back once the lesion is released. The kilopascal is quite low. Score 2 is majority is deformable. There is minor stiffness. Score 3 is central stiffness. The periphery is deformable. This is coming to a Birads 3 lesion. And if it becomes completely stiff, it is score 4. And if it's stiff with surrounding non-deformable lesion, that means there's a good amount of desmoplasia around, and that is what would actually categorize as a score 5 lesion. So the keywords for elastography is that it has got a tremendous role in defining the Birads 3, 4A, and 4B lesions. It has got a role in complex cystic lesions. It has got a role in establishing by the kilopascal and adding the color code on the gray scale that we normally see. Now, coming finally to the perspective, as I said, we are not discussing on patients who had come to us on a screen detected mammogram with a small little microcalcification or an amorphous single-ended microcalcification where you have doubt. And in these cases, you need to put how much resource you are going to invest on them. Are you going to do a biopsy, which is going to be a stereotactic biopsy or an ultrasound guided biopsy or a roll in them? For us, it's quite simple. You can just go for a core biopsy. Now look at what is the algorithm or the guideline in the West. You can choose any of the evaluation modes by a radiology guided core or a wire localization. In some place in Italy, they would use the roles. So the guideline is very clear. You have a screen detected lesion, R1 or 2 observation only. If it's an R3 or a Birads 3 lesion, where you have a doubt like Mona Lisa, how this lesion is going to behave and what's the emotion of the lesion, you have planned for a follow-up at 6 months, 12 months and 24 months. Anything above that, you need an evaluation to certain extent. But what might happen? In practice, what happens is that 8% of them on follow-up gets upgraded to suspicious and will need a biopsy. I was looking into the data of follow-up of or the recall of the patients who have been on follow-up. And the biggest data that shows in a country who had got a robust screening mechanism is at 6 months, 90% will turn up. In 12 months, 80% will turn up. In 24 months, only 59% is going to turn up. So for a country like us, whether it's justified for a palpable lump where you have a Birads 3 lesion, to put the patient on a follow-up is a big issue. And therefore, I would actually deviate the practical guidelines to certain extent. And in for us, for Birads 3 lesion, if you suspect that the follow-up compliance is going to be low, there is no harm in trying to evaluate them by the tools, either a guided core or a wire guided localization, to understand and then prove whether it's a NCB4 or a NCB5 lesion before asking the patient to come back after 2 months, 2 years, and the patient might disappear in between. So coming finally, as I said, for us, it's easy. You have a lesion which has got a 4 centimeter lump. The Birads category is 3. You are going to go for a triple assessment. And I would ask you for an ultrasound guided core in them, because if you do an ultrasound guided core, your diagnostic accuracy, the positivity at the specificity and sensitivity, both is going to go up. If even after doubt, there is doubt, you can choose to have a frozen section. And even that, if you don't have a frozen section, you are at your will to excise the lesion and send it for a biopsy. If it comes out to be malignancy, you can call back the patient for re-excision. But in the West, the situation is not like that, because these are impalpable 5 millimeter amorphous microcalcification, where it's more challenging to deal with it. Coming finally to the take home, Birads 3 lesion need follow-up for at least 2 years. In the Western perspective, focuses on screen detected impalpable lesions. The Indian perspective focuses on palpable lesions. And for us, once again, I must re-emphasize the importance of triple assessment and an ultrasound or a mammo-guided core biopsy in a patient who has got a Birads 3 lesion. Thank you very much. Happy to take any questions.
Yeah, thank you, sir. It was a nice eye-opening talk on Birads category 3. I would request Shinde sir to add on his comments. And if any questions are there, they are invited.
Thank you, Darshana, and congratulations, Dr. Sarkar. You have presented such a nicely elaborative and depicted with the photographs that each and every lesion, how it looks, what to do, what not to do, how to progress with the or add on the investigations, and when to add on the investigations. This is such a wonderful self-explanatory lecture or the talk on the Birads 3 lesion. I think there should not be any question, but if anyone has, like me, I have one single small question. Like you have mentioned about the even cortical thickness as a intermediary lesion or the malignancy, but what books or the references say the eccentrical cortical thickness in the malignancy is suggestive of malignancy. So is it eccentrical cortical thickness, or it is the even cortical thickness can be considered as a part of suspicious of secondaries from malignancy? That was my one single question.
Sir, you have rightly pointed out I didn't tell. I was just emphasizing on the postgraduates to look at cortical thickening.
Yeah,
Yes, the earliest one, again, there are subtypes, 5 subtypes. The earliest one will be an eccentric cortical thickness. Then there will be an uniform cortical thickness. Then there will be hilar fat replacement. And finally, the globular shape. But the earliest, as you rightly pointed out, would be an eccentric cortical thickness. And therefore, the residents should train their eyes, as you rightly said, looking at the cortex to find whether there is any thickening or not.
Right, sir. Thank you very much. And if anyone has any other question, it is welcome.
Sir, I have a question, Dr. Dipten Sarkar. I am Dr. Anjali Dawle, sir.
Oh, hi, Anjali.
Hi, sir. I always tell others, and I was discussing with Yeola madam, that Dipten sir doesn't only give the talk, but he sings the song of the breast, and that is really true, sir. My one question is, sir, because in the medical colleges, we see maximum cases where we have a giant fibroadenoma category when we have a strong suspicion of a cystosarcoma phyloid or a phyloid tumor. The FNAC or the core needle biopsy is telling us that it is a fibroadenoma. If we just on the basis of fibroadenoma, if we go for enucleation of the tumor and not the wide local excision, the histopath report comes to be the phyloid tumor, and then the challenge starts. Now, in this case, as a district surgeon and as a medical college teacher, where whoever are attending, I am not into the medical college, but the real challenge is, sir, now if we have enucleated, the histopathological report is a low-grade phyloid tumor. They advise you go for the immunohistochemistry stains, but many of our basic labs do not have a differentiating feature of a high-grade pathological labs. In such scenario, how to progress, sir? How to go ahead?
Excellent question, Dr. Anjali. I mean, it's not your problem. Truly speaking, it's a problem of even people practicing in the metro cities. I mean, theoretically, it's fine to tell that every patient must have a core biopsy done, but practically, it's so very difficult that somebody has come from a reputed lab with a fine needle aspiration cytology and start telling him it doesn't really matter and you need another core biopsy is quite difficult, particularly in private practice. So what I have started looking is initially look at whether I find the clefts or not. If I find in ultrasound there is a cleft, I will go for a wide local excision. If I do not find a cleft, it appears to be fibroadenoma, and I excise, and the lesion comes out to be a benign phyloid tumor, I only tell the patient that this is a benign lesion. The chances of local recurrence is 20%. I would advise you to be on follow-up at this present moment with a 3-monthly follow-up for first 1 year, then 6 monthly for another year, and after 2 years, if the lesion doesn't come back, you are more free. But if the lesion comes out to be a borderline lesion or a malignant lesion, I will call back the patient and go for a cavity shaving. So you don't require an excision if it comes out to be a low-grade phyloid tumor. But you need to put the patient brain this fact that yes, this is a lesion which can have recurrence.
Okay, thank you very much, sir. One more query I have, that lot of literature is coming on that giant fibroadenomas, they have a strong tendency to turn out into the phyloid tumor. So, in this stage of transformation, what is the picking up sign, sir, clinically and investigation wise?
Clinically, a giant fibroadenoma, unless it's a very big phyloid tumor, is very difficult. And I have been operating on patients who have got a fibroadenoma 3 centimeter came out to be phyloid tumor. Hopefully, I go for core biopsy if the patient comes virgin to me. But there are patients who are coming with an FNAC coming from a good reputed lab and done by another reputed surgeon. It's very difficult to tell that you throw this away and go for a core biopsy. But if I have a strong clinical suspicion, I would tell that, well, he must have done it with the best interest, but I think you need a core biopsy. I will go ahead with a core biopsy. Having said that, again, this is an issue. I always have in mind that if I do not see a cleft, then I still feel it's a fibroadenoma. But if I find a cleft, because till now I have not seen a single phyllodes tumor which did not have an intralesional cleft. So kindly look for the intralesional cleft before you take the patient to theater. And that's the advantage of doing a triple assessment.
Right, sir. And one more thing, sir, for the sake of the postgraduate students who are attending here, we have a scenario of presentation in a case of fibroadenoma presenting from a small fibroadenoma, medium fibroadenoma, large fibroadenoma, and a phylloid tumor. This transformation category, that when you will say that this is a small fibroadenoma, don't intervene. When you will say that this is an intermediate grade, and when you say that this is a warning sign where you should excise, even though family history is not very positive. So for the sake of postgraduate students, sir, just define when it is an adenoma localized and when it transforms into a disease as such.
Okay, this is a very interesting question. Number one, the Western guideline is 4 centimeter below or above. What I have modified and which I have implemented in my breast service at IPGMR is that we have made it very simple, 30 years and 3 centimeter. So if it's a less than 30 years, it's a less than 3 centimeter lesion, it's a triple negative lesion, that means all triple assessment has been done. Then I ask the patient to be on follow-up for 2 years, and the follow-up schedule is 6 months, 12 months, and 24 months. If the lesion has not progressed in 2 years' time, it is unlikely that this lesion is going to progress. But if a patient comes with more than 3 centimeter, or a patient comes from a distant area where the patient is unsure that he or she is not going to come back about the follow-up, it's a good practice to go ahead with an excision, even if it's a 2.5 centimeter lesion. But multiple fibroadenomas less than 2 centimeter or a single fibroadenomas less than 2 centimeter, there is no way one should put the scalpel into the breast.
Thank you very much. I think that is the most concluding and the remarkable message which every PG should listen to it. Over to you, Madam Darshana, ma'am.
Thank you, sir.
Sir, I want to just ask one question.
Yes, ma'am.
Related to phylloid tumor. Sir, we are having the patients of recurrent phylloid tumor. So how to go ahead? Whether we should go ahead with simple mastectomy followed by radiation, or just again re-excision of the tumor? Just highlight on that.
Madam, that's an interesting question. I would go for re-excision. I have had patients whom I have re-excised 7 times. I finally ended up in resection, but in a phylloids, I would always add some sort of, as I said, some sort of reconstructive procedure. It's unjustified to go for a simple mastectomy. Whatever big the lesion is, even if I am able to see 20 to 30% of the breast tissue intact with the standard reduction mastopexy techniques or a volume fill up with a latissimus dorsi myocutaneous flap, you will be able to give back a decent breast to this lady. So as a policy, I will never go for mastectomy if it recurs, unless it is a huge one, but there is no scope. I will go for revision excision. But the only concern is in some patient, I find that they have turned into more the number of recurrences, and the recurrences are multifocal. There is a possibility of them getting converted into a frank sarcomas. In these lesions, I won't take any chance, would go for a mastectomy. But again, PGs need to understand that there is no role of an axillary lymph node dissection in these patients.
Current radiotherapy?
Radiotherapy is there, the evidence is very weak, and though I have had some of my patients in whom the radiation oncologists have advised radiation, but I would take that with a pinch of salt. There is no strong evidence in favor of radiation.
Okay. Sir, and I want to ask again 2 questions. 2 extreme of ages, the young female with multiple tender fibroadenomas, around 18-20 years of age, and they are so much worried. So what to do in such cases? And the second age group in perimenopausal age group, very tender breast, severe mastalgia, how to go ahead in 2 scenarios? Just
Yeah, madam, of course, if there is no lump, it's just very tender, extremely tender breast. Yeah. Now, I have already published it and had presented this in the ABS last year. One of the reasons that is a gross vitamin D deficiency, and around 72% of the patients, they will have some sort of vitamin D deficiencies. And with the placebo control, I found there is a strong association between breast pain and vitamin D deficiency. And supplementing with vitamin D, around 72% plus patients, they have a reduced pain. The next option, of course, is to be on become a counselor. Go on counseling the patient time and again. If you choose to give tamoxifen, I would not advocate tamoxifen in young group, though it doesn't cause any problem. But the problem is they go to internet, they find that tamoxifen is a drug for malignancy and can produce menstrual irregularities. So in young age, they would come back and telling, doc, I won't advise this. So in an elderly patient, yes, tamoxifen 10 milligram thrice weekly for 2 to 3 months reduces the pain to certain extent. Tamoxifen 10 milligram thrice weekly.
thrice alternate day.
Alternate day.
Okay.
Alternate day.
Okay. And sir, a young age group, adolescent age group, multiple tender fibroadenomas. It is just reassurance?
Reassurance and reassurance. After some time, you become their family members.
Okay. Thank you, sir. Thank you very much.
Thank you very much.
Sir, good afternoon. I have a question.
Yeah.
I'm Dr. Amit. Sir, regarding discussion on giant fibroadenomas, I worked in a unit of a good surgeon who used to practice all the giant fibroid. If he was going for enucleation, he would section it on table and see if there are grossly, if there are clefts inside, or if there is any hemorrhagic material. So on the same in the same OT, in the same sitting, he would shave the margins. So in 2 cases in last 1 year, he was able to actually save the patients from resurgery for taking patient into resurgery at a different setting. So what is your comment on this? Observing the specimen on table, grossing the specimen on table, and seeing for clefts and hemorrhagic material inside.
That's quite interesting, Dr. Amit. But as I said, I actually spend at least a minute on the ultrasound plate. If I see a cleft before I go ahead with the surgery, then it's quite obvious that this patient is a phylloid tumor. I will excise with a wider margin. I understand the gentleman who is doing this is following the same principles, just that in the operating room he is doing that. But again, as I said, if you look at the ultrasound very thoroughly, it's seldom that you are going to miss a cleft.
Yes. So, but the quality of breast radiologist, or the since we very few radiologists are actually into breast radiology, so most of the times it is the reporting of mammogram or even the breast ultrasound is not that adequate what the breast surgeons or breast consultants would be requiring. So do you think, being a very highly placed and influential person in ABSI, would you think that this...
I would endorse that, whatever you suggested. At the end of the day, India needs to find its own solution. And therefore, if somebody is doing this, it's fine. It's a way to Atmanirbhar Bharat. That's what I can only tell on a lighter mood. But yes, these are Indian innovations which need to be taken into account. And that's a good practice. I must congratulate the gentleman who is doing that.
Hello, can I intervene?
Thank you.
Yeah.
Thank you, sir. Thank you.
I think there are clear guidelines related to the benign or malignant diseases or phyloid. There are clear guidelines how to approach that. Our concern is what should be or how to evaluate and then go ahead with the Birads 3 lesion. So as you correctly mentioned that initial evaluation with the ultrasound and other than the triple assessment, we have to add the sophisticated investigation so as to explore the details of this grade 3 or the Birads 3 lesions. And depending upon the evaluation and ending up either in benign or in the malignant lesions, we have to go ahead. I think this should be the ultimate take-home message for this, that we have to first categorize with the available investigations and the lacunae that have been found on the basic investigations, and then go ahead with the as per the guidelines related to the benign or the malignant investigation lesions.
Thank you. Yeah, I completely agree with you.
Thank you, sir. There is one query in the chat box I would just like to add on. If the patient is an adolescent age group, with multiple fibroadenomas and having bulky breast, what should be the plan of management? Is there any role of reduction mammoplasty and surgery or just conservative treatment?
Yeah, this is if the patient chooses to have a reduction mastopexy, that's fine. But again, I would tell the gentleman or the lady who has given this question that do not go for reduction mastopexy so early. You must at least wait for the teens to be completed before you choose a reduction mastopexy. Because you do a reduction mastopexy perfectly done and the base hypertrophies after the age of around 18 years of age, your whole surgery is wasted. So take the patient through to the teens, and after 18 years, when you see that there is no further progress, then actually you can choose to have a reduction mastopexy. And if you're doing a reduction mastopexy, you might as well take out the fibroadenomas if it is restricted to the quadrants from you are taking out, because preserving the vascularity in a reduction mastopexy is an extremely important issue. So you cannot make an incision here and there to take out the fibroadenomas.
Thank you, sir. So after such an extensive discussion on the topic, we'll move on to the next lecture of the session.